So let's discuss up the questions of microbiology in this particular CPOT. And as the exam have got postponed, the only challenge is to maintain that streak which you are having, okay, that flow of your studies. And I know, like after some distractions and all, you will come back. And in that series only, let's start up with this particular discussion so that you can get up most of your questions in and around these particular stuffs right in the exam. Okay. Now let's see the first one. A 24-year-old male presented to the emergency with complaints of abdominal pain. The patients gave a recent history of consuming undercooked ground beef. The patient has no complaints of fever. On examination, the skin turgor decreased, and the investigation revealed the presence of RBCs on the stool microscopy. Okay. So, which of the following bacteria is responsible for his condition? So, one thing is understood. Skin turgor decrease means the dehydration happened, and there is a presence of RBCs. So, means it's a sort of blood which is coming up in the stool, a sort of dysentery type episodes, bloody diarrhea, as you can say, and there is a history of eating up this. So, this characteristic history is regarding the enterohemorrhagic E. coli. Okay, guys, you already know that enterohemorrhagic E. coli O157H7. This particular serogroup O157H7 is responsible for doing up HUS, which is termed as hemolytic uremic syndrome in the children, and it does hemorrhagic colitis in the males. Okay, and this particular HUS presents with what? It presents with renal failure, it presents with anemia, okay, and thrombocytopenia. So these particular things are there. That is renal failure, anemia, and thrombocytopenia. That is happening in the HUS. Regarding the hemorrhagic colitis, this one happens in the adults mainly. Okay. Now, other than that, this is a favorite of examiner in the NEET PG. A lot of questions are being asked in and around this. So, we should discuss them also. So, what should be the other ones? That it have certain toxins like VT1 and VT2. Okay. And these VT1 and VT2, what is the other name of them? They are also termed as virocytotoxins 1, virocytotoxin 2. Okay. And they are termed as this also, SLT1 and SLT2. And what is SLT, guys? Shiga-like toxin. Okay. So that suggests what? Shigella. Shigella does what? Invasive infections. So this also does invasive infections, and that's the reason why you are getting up the RBCs in the stool microscopy here. Okay. So that is one of the reasons. Another important question which was asked in one of the exams is, this is being produced by whom? A gram-negative bacteria. So gram-negative bacteria mainly produces what? A endotoxin or exotoxin. So mainly they secrete endotoxin. But to your surprise, this particular thing is what? This particular thing is exotoxin. Another question asked. Then if somebody asks you regarding the culture media of it, the culture media is also unique because it does not ferment the sorbitol. That's why use of what? A media termed as SMAC agar. And what is that? Sorbitol McConkey agar. That is the SMAC agar. And why we intentionally use it? Because it does not ferment the sorbitol. Okay. The other one, other than SMAC, you can use up the rainbow agar. Other than that, what you can use up? You can use up the rainbow agar for this particular one. Is it fine, guys? So answer is B. And this characteristic history also associates with this only. So next time, this association should also be in your mind, that eating up this particular product can lead to enterohemorrhagic E. coli stuff. Is it fine, guys? Now, 14-year-old boy with fever, joint pain, a recent history of sore throat. On the hospital admission was necessary for this particular child. The hemoglobin levels were found to be 8.8, less only. The total leukocyte count is 11,000 per cubic mm. ESR 65 mm. On examination, the heart rate was found to be 112 per minute. A loud murmur is heard on the auscultation, and echo suggests the vegetations are present in the cardiac walls. Okay. So basically now as you measure with the ESR and all, so that is termed out to be 65 mm here. So basically vegetations on echo, that comes in the major criteria of Duke's. That is the Duke's criteria. And we are talking about what, guys? We are talking about infective endocarditis. We are talking about which particular disease? Infective endocarditis, which have in the major one and the Duke's criteria, the echo findings, vegetations, and other one is culture, and that is blood culture. Is it fine? So this is one of the points, and other than that, the minor ones, the major and minor criteria is there, na? So the minor criteria, you have the other ones like those who must be knowing Janeway's lesions, Osler's node, okay, all those particular ones, they are observed in the infective endocarditis, rot spot, all sorts of those lesions, they are there in the minor one. So basically, you should know here, obviously, that which one does what, and the most common cause of infective endocarditis, as such, also you know, that is termed as native valve endocarditis, and the native valve endocarditis most common cause is Staph aureus. Okay. So this you need to know first of all, that what is the most common cause of NVE, and what is NVE? Native valve endocarditis. Other than that, there is this particular thing termed as SABE. Okay. SABE, everybody knows, is being done by whom? Streptococcus viridans. Okay. And remember here only the other name of it, that is termed as ABE. Okay. So might be by this name the question came like in one of the exams, and again it can come. So ABE is what, guys? Acute bacterial endocarditis. And what is SABE? Subacute bacterial endocarditis. And that is being done by this viridans. And the native valve is done by what? Native valve is done by Staph aureus, which is also known as ABE. ABE is acute bacterial endocarditis. Another thing is IV drug abuser. If somebody is an IV drug abuser, overall also the most common cause is Staph aureus, and right-sided valve involvement, that is tricuspid valve, is involved by whom? That is the Staph aureus. So in IV drug abusers, you should remember up Staph aureus as the main culprit in doing what? Infective endocarditis. And now the question which came in the last exam, that early prosthetic valve endocarditis. If I talk about this, early prosthetic valve endocarditis, if I'm talking about this particular one, then what we are talking about? Early prosthetic valve endocarditis means somebody's valves got damaged and you repair them, and within 1 year they also got damaged. That is termed as early prosthetic valve endocarditis, and it is being done by what? It is being done by Staph epidermidis. And you know, this particular name comes where? This particular name comes in the cons. Okay, this particular name comes where? In the cons. So after this particular one, like I like to tell up, if there is a history of dental surgery and all, then you have to like focus upon sanguis and mutants. Otherwise, these particular names is there for the infective endocarditis, various stuffs. Fine. Now coming to this, a 5-year-old child brought by her mother to the general physician. She complains of recurrent wheezing and sneezing episodes of her child, which occurs mostly in the month of April. Okay, so basically the season is being given, that to the spring season. Which are the following immunological mechanisms responsible for this symptom? So obviously this is seasonal allergy. Okay, so a sort of allergy stuff, and obviously toll-like receptors by pathogen-associated molecular patterns, that doesn't go with this. It is mast cell activation through the IgE binding. This is what is the best answer, because they are asking regarding the hypersensitivity stuff, and this is what is the type 1 hypersensitivity is all about, allergies. Okay, IgE mediated, mast cells are involved up, there is a primary sensitization and re-exposure again. So those things are involved in this. Important is which particular helper cells are there in the type 1 hypersensitivity. So remember, in type 1 there is T helper 2 cells, and they secrete up interleukin 4. What they secrete up? Interleukin 4. And what these interleukin 4 does? They do the isotype switching. Isotype switching is what? That IgM changes up to IgE. That sort of isotype switching is being done by this interleukin 4. And what you have? IgE now, and these will sit over what? These will sit over the mast cells, and in the second exposure, when they are sitting over it, this particular mast cells ruptures. Okay, this particular mast cells rupture, and rupturing of the mast cells release histamine and serotonin, and this is what you find in the type 1 hypersensitivity. Okay, so this is logical regarding the B option of this, regarding the allergies and all. So here I am like to tell you, in the type 1 hypersensitivity, T helper 2 cells are involved up and they release up interleukin 4, whereas in the type 4 hypersensitivity, if somebody asks up, T helper 1 cells are involved and interleukin 2 is released along with interferon gamma, and they does what? They does the formation of granuloma there. Okay, so remember that particular point also. Okay, now coming to the next question. In order to reduce the risk of severe dehydration, which of the following childhood infections can be prevented by administration of vaccine? So, options are Group A, rotavirus, enterovirus E. coli, then Norwalk virus, and then Campylobacter jejuni. These are the various options, and obviously you know the vaccine is there for rotavirus. So, answer is Group A, rotavirus, which is the most common, which does the rotavirus diarrhea. Okay, other than that, there are like 9 others which can, the various groups of rotavirus, and this is what is the most common cause of diarrhea in children. This is what is the most common cause of diarrhea in whom? In children. Okay, so this is an important point to be known, that most common cause of diarrhea in children is rotavirus infection, and that too which rotavirus? Rotavirus A, that is Group A rotavirus. Is it fine, guys? Other than that, what else needs to be remembered in rotavirus is that this is a double-stranded RNA. Okay, this is a double-stranded RNA and it is having a segmented genome. Okay, this particular one is having a segmented genome, and like total number of this particular one segments are around 11. This is having the segmented genome, that is RNA, double-stranded RNA. And is it enveloped or non-enveloped? So this is non-enveloped. So guys, this is also very important, which you should know. And what is the investigation of choice for this? Rotavirus antigen detection by ELISA. Rotavirus antigen detection by ELISA. This is what is the investigation of choice for this rotavirus infection. Is it fine, guys? So remember this particular one. Other than that, those particular names like NSP4, non-structural protein 4, responsible for what? Secretory diarrhea. And other than that, what you need to know is that NSP4 responsible for secretory diarrhea, and Rotavirix and Rotatec, these are the vaccines. It comes by the name of Rotarix also. They are the ones which associates with the side effect that is termed as intussusception. And now they are in our national schedule also. So that is also an important point to remember regarding the rotavirus. Now coming to the next one, Geobacillus styrothermophilus spores. They are used as a biological indicator in which of the sterilization methods. So you know this simple one, autoclave and plasma sterilization. Autoclave, you know the temperature autoclave, 121, okay, for 15 minutes at a pressure of 15 psi. So actually what happens in this particular one, that is the usage of biological indicator, so that they come in the form of vials, Bacillus styrothermophilus, and basically what happens, you put them into the autoclave, you raise the temperature to this particular temperature for 15 minutes, 15 psi, and after that you keep this into the incubator. Okay, you keep this into incubator for growth. So if the growth happens up, nowadays the newer versions of this have come, in which there will be a color change. There will be a color change if the spores are not killed. Okay, so there will be a color change. They will become colorful after some time, after the incubation, and if they do not change the color to the blue and all, that means your indicator is working fine. You got my point? Before they used to culture it on the culture plate, but nowadays they see the color of the change which happens up. And why the color will change? Because they will grow and they will try to produce up a color which is being already put up into the biological indicator. Otherwise, they could not able to produce that particular color. Okay, so basically nowadays it's about the color. If it is there, then it's a control failure. You should check your autoclave. It is not achieving the temperature of 121. Okay, so that particular thing is there by this. And which is the latest method for sterilization? Plasma sterilization. And the question of aims was that which particular gas is used in this. The H2O2 gas is used in this. Along with that, electromagnetic radiations are there in this. Vacuum is there. Okay, low temperature is there. And all these factors, they produce what? Radicals. And because of that, ion formations or radicals, the sterilization happens. So this is what is the latest method termed as plasma sterilization. Is it fine, guys? Now, a 45-year-old man is recently diagnosed with systemic candidiasis. So systemic candidiasis is something happening to somebody. So obviously, one thing is very clear, that the person is immunocompromised in some sense and is currently on a broad spectrum antibiotics. Which of the following statement is true? Okay, which of the following statements is true? So basically, the gram staining shows gram-negative oval budding yeast. This statement is wrong. It is not gram-negative, it is gram-positive. If at all you are gram staining it. The colonies appears to be black, smooth and pasty. No, it is creamy. Creamy, pasty, but not so tasty colonies on SD agar. On cornmeal agar, the Candida albicans produces distinctive thick-walled chlamydospores. This is what is the correct statement. You know that on this nutrient-deficient media, it produces chlamydospores. And other than that, it shows up the germ tube formation also. Which one? The Candida albicans. The germ tube formation is an important feature which Candida albicans shows. Germ tube test is specifically done for Candida glabrata? No, I just told it is done for Candida albicans. So these are the factors which affects of the candidiasis and all. I already told up if somebody is developing of systemic candidiasis, so obviously that particular person is immunocompromised in some sense. That's why he is developing up the systemic candidiasis. Fine. Besides that, the question which recently came in the FMG exam, that because the board is same, it can come to you also, that a lady is there with having discharge, thick curdy white discharge. By that you get information about the vaginal candidiasis done by that. Along with that, what you need to know is, like in the Candida, you have hyphae, you have pseudo hyphae. Okay. Even you have yeast-like, means it can show the all forms of existence. Okay, got that? So it can form all sorts of existence. Which fellow? This particular fellow, which one? Candida albicans. Is it fine? Now, regarding the scrub typhus, if they are asking up which of the following statement is accurate. So basically, if we ask up this way, that which is the statement which is accurate, so let's see. The first one, it is also known as Rocky Mountain Spotted Fever. No, guys, it is not Rocky Mountain Spotted Fever. That is different thing. That is being done by whom? That is being done by Rickettsia rickettsii, whereas the scrub typhus is being done by Aurantia sussugamosi. The classical presentation involves an eschar, a black eschar, regional lymphadenopathy, and a maculopapular rash. Very right. This is what is the triad which is being observed in this particular one. Besides that, in the scrub typhus, it is being transmitted by what? Trombiculid mite. Okay, it is being transmitted by mite, and the larval form of this is termed as chigger. So that's why the disease name also comes out to be what? Chiggerosis. Remember this particular one. And here, what I like to tell you, that it is common in the hilly regions and all. And in the hilly region and all, this particular one produces up the disease. And disease is what? Having a fever. Okay. Along with that, there is a myalgia, and as given up in the question, eschar along with regional lymphadenopathy and a rash. So these all are features of scrub typhus, and this disease is common in India also. Okay, this particular one is common in India also. Fine. Another thing is, for this you do a test that is termed as Weil-Felix test, and Weil-Felix test is what? OXK strongly positive. Okay, and that is regarding the scrub typhus. Okay, OXK comes out to be strongly positive, and that is for the scrub typhus. Is it fine, guys? Now, it is mainly reported for urban areas. No, hilly regions. It is reported mostly for the hilly regions, and in the rural area it can be. Urban areas less. Causative organism is anaplasma. No, I just told up the causative organism is Aurantia sussugamosi, and it is transmitted by what? Mite. What about the anaplasma? Anaplasma, this question came in the, AIMS exam. Anaplasma phagocytophilum. As the name suggests, it involves which fellows? Phagocytes. Okay, it involves the phagocytes, and this particular disease is tick-borne. Okay, this particular disease is what? This particular disease is tick-borne. It is spreaded by the tick Anaplasma phagocytophilum is the organism name, and this particular one does what? It does this. That is human granulocytic ehrlichiosis. Human granulocytic ehrlichiosis. This is what is the disease name, in which obviously what increases up the granulocytes, okay, as the name suggests. And where you like basically culture them, you culture them into the human phagocytes only, and there they have a morula-like appearance. This question came, and they all are tick-borne diseases. Now coming to this, a 2-year-old girl presents to you with fever, sore throat, okay, and you suspect of the swollen lymph nodes here. An enlarged spleen on palpation is observed, and a monospot test is done. It comes out to be positive. What is the likely causative organism you are suspecting? So basically, the age 2-year-old girl is it can happen. Yes, it can happen in this age also. But mainly, what you will get in the exam is like a young age. Fine, because they are talking about the kissing disease. It spreads through saliva. Okay, common among the young age, but here also it can happen off. It is not so that it can't happen in a 2-year-old girl. Okay, but obviously not by the kissing and all, by the salivary contact of any sort, it happened. So basically, this you know that it is being done by which particular virus? Epstein-Barr virus. And what is the number of the Epstein-Barr virus? HHV4. What does this affects of? It affects of the B cells. Why B cells only? Because B cells have on their surface CD21CR2, and that's why they are attracted towards it, and leads to the polyclonal proliferation, and thereby leads to number of carcinomas. And this disease which is being discussed in the question, infectious mononucleosis, which presents with what? Which presents with sore throat. Okay, and sometimes in this disease, what can happen? A formation of pseudomembrane. So there is a formation of pseudomembrane in this particular one. This also you need to know. And in the case of infectious mononucleosis, even the CD4-CD8 ratio can reverse off. That is also an important point to be known. Is it fine? And for this, we do the PCR for the IBNA and the VACA. And VACA is viral capsid antigens. And the organism is herpes virus, HHV4, human herpes virus 4. Okay. Now coming to this one, wherever you see diabetic, immediately a lot of diseases should come in your mind. One of them is this, which is there in the question. Physician with a facial pain and a black necrotic skin lesion beneath the eyes. The patient is non-compliant to the medications, hence suspecting his blood sugar level to be poorly controlled. Okay. The physician advised for a skin lesion biopsy, which reveals non-septate hyphae with wild angle branching. So obviously, in the question itself, everything is being given off that they are talking about a diabetic patient, which is immunocompromised in some sort, complaints of facial pain, black necrotic skin lesions. They are talking about an invasive lesion, rhinocerebral zygomycosis, okay, which can enter into the orbits and all. So basically, this is the rhinocerebral mucormycosis or zygomycosis. And for your information, I should tell that the third name is also there, that is termed as phycomycosis. And when this necrotic lesion, which is because of the angiothrombosis here, you take up this black necrotic lesion, okay, you take up this black necrotic lesion and this black colored lesion, black crust lesion, and put into 10% KOH or H and E stain, what you get this particular type of feature. Okay, and what is that? Aseptate hyphae, obtuse angled. Okay, obtuse angled aseptate hyphae. Fine. So this is obtuse angled aseptate hyphae, which mostly is found wide angled it is, and it can be in this form also, that the angle is 90 degree, but this is for sure that this is aseptate. Got my point? And why we are talking about all this mucormycosis nowadays a lot? Because in the case of COVID, these infections, they were very common, and this you already know that this is not a black fungus. Mucor is not black fungus. Actually, it is a black fungal disease, which you can say. The black fungus is what? The black fungus is Phyllophora and Cladosporium. You got my point? This is not black fungus. If somebody says that mucor is black fungus, no. It causes black fungal disease. And why does it cause that? Because of angiothrombosis. Okay. The second option, which is aspergillosis, you know, in that you have dichotomous branching and angle of 45 or 60 degree, and this is having the septa. Okay, this is having the septa. Now, coming to this, while playing the street, a child was bitten by a dog on the both right leg at 2 sides, okay, and left arm at 1 side with constant oozing of blood. So there is a constant oozing of blood, and the sides are 3 round off in this particular one given. What treatment is required according to WHO guidelines? So you know, guys, that is class 1 bites. It's just a licking over the intact wounds or intact skin. Second one, it is licking over the broken skin because of some lesion or some injury. There is a broken skin. Over that, the licking happened up. That is class 2. And class 3 bite is this sort of bite in which there is a constant oozing of blood. And for the class 3, you know, it is not the observation because this is an emergency. Okay. So only wound management? No. Wound management along with rabies vaccine administration? Fine. Monitoring the dog's health for 10 days? This is okay. But important is wound management, rabies immunoglobulin immediately is to be given up. Which one? Either human or either equine one. Okay, the human is given in the units of 20 units per kilogram and equine is given 40 units per kilogram. Rabies vaccine administration, that is 0, 3, 7, 14, 28, that is being given off, and you have to monitor of the dog's health for how many days? 10 days if this happens. So answer is D. This is class 3 bite managed in this particular way. For the class 2, you just give PEP after the wound management. If at all something is there, graze and all, you have to manage that particular thing. There is no oozing of blood. Whereas in the first one, class 1 bite, what happens? In the class 1 bites, just a lick over the intact skin. So you just have to clean it off. A patient presented with painful micturition. Painful micturition is a feature of UTI with increased urgency. Another feature, frequency. The clinician suspects the lower UTI. Okay, and he runs some lab investigations. He runs out some lab investigations, and according to that, the cause concept of significant bacteria, which statement is accurate here? So guys, a bacterial count of more than this, that is 10 to the power 5, more than 1 lakh CFU per ml is deemed as significant. Very right. This is what is termed as significant bacteriuria. This is termed as which particular feature? This is termed as significant bacteriuria, also termed as asymptomatic bacteriuria. This is also termed as what? Asymptomatic bacteriuria. Okay. Means in this, like significant bacteriuria, this can happen, asymptomatic and all. But what you can say here safely, that the person is having the features. So you can't say it is asymptomatic, but this statement of this, that is more than 10 to the power 5 CFU is deemed as significant for sure. Yes, it is there. And even you can say in those patients also very confidently, those who don't have the symptoms, means they don't have urgency, they don't have frequency, they don't have these features of painful micturition and all, they also should be treated because they will be getting this UTI infection very soon. You got my point? Okay. A bacterial count below this suggests an uncertain significance. So this is a wrong statement. The bacterial counts ranging from 10 to the power 4 this are attributed to the presence of commensal bacteria. Not exactly. The criterion is rooted in the understanding that normal urine is not entirely sterile. Because of that only this is there, but not the complete statement. The complete statement is the first one. A bacterial count of this in the cause concept is deemed as significant. Okay. And you can say here the features were given up, that your job is easy. Otherwise, in the asymptomatic also, you need to treat. If this particular number is coming off E. coli, Klebsiella or any other bacteria, and what is CFU? Colony forming units. Okay. I hope this is clear. What are the screening tests for the UTI, guys? Can you tell me? Grease nitrite test, leukocyte esterase test, catalase test. These are the screening tests. And what is the confirmatory? Confirmatory is culture. Culture on which media? CLED. Why? CLED is preferred because it is non-selective. Got my point? Which of the following statements is incorrect regarding the pneumocystis pneumonia? Pneumocystis zerovicii pneumonia, obviously. Okay? The PCP is also termed as, PCP is also known as plasma cell pneumonia. This statement is correct. It is also termed as plasma cell pneumonia. The CT lung imaging typically shows ground glass opacities, that is GGO. True. This is also true. Okay. The causative agent is pneumocystis zerovicii, as the name only suggests pneumocystis. So that is, the causative agent is this only, but controversial it is. Some says it's a fungus, some says it's a protozoa because it exists in citral trophozoite. And even one more interesting thing is that it exists in like commensalism with whom? With trichomonads, that is Trichomonas vaginalis. So that infection also is common in these fellows, if obviously that's female and all. this particular infection is common with pneumocystis cerevisiae infection. So this can come. It correlates with each other infection. The pneumocystis can't be cultured. Very right, it can't be cultured. Serological tests are used for diagnosis. No, guys, you know that the sample of choice is BAL, or another one is termed as gastric washings. So one is BAL and one is gastric washings. And what is BAL, guys? Bronchoalveolar lavage fluid. Okay, bronchoalveolar lavage fluid is taken by the bronchoscopy, and other gastric washings. And you put this particular stuff into what? You put it into the GMS. And what is GMS? Gomori methamin silver. And because of that, the cyst turns out to be black, and our trophozoite here turns out to be green. Okay, this is turns out to be green. So cyst turns black. Okay, cyst turns black, and the trophozoite turns green. That is G for G. Okay, and why the cyst turns black? Because it has glycogen in it. And one important thing is it has glycogen, and it looks like a crushed ping pong ball appearance. Is characteristic of the cyst in the case of pneumocystis cerevisiae pneumonia. At which CD4 count it happens? It happens at CD4 count of less than 200. And which drug of choice you use for this? That is cotrimoxazole. That is cotrimoxazole. Is it fine? Now coming to this, which of the following organisms responsible for causing cat scratch fever or cat scratch disease? This you already know, Bartonella Hansley. So Bartonella Hansley, I already told up in the class also that you were playing with your cat, that is the pet, and haste that she scratched you. So the Bartonella Hansley does the cat scratch disease, which is also termed as, this cat scratch disease is also termed as what, guys? This particular cat scratch disease is done by this Bartonella Hansley is having certain granules, which is being asked, that is the stellate granuloma. So stellate granuloma is seen in this, and there is involvement of the various viscera like liver and spleen in this particular one disease that is done by this cat scratch disease. Chaffinensis, Ehrlichia chaffinensis, this leads to human monocytic ehrlichiosis. Human monocytic ehrlichiosis, and as the name suggests, what is increasing of in this? Monocytes. Then have Rickettsia rickettsii. This leads to Rocky Mountain spotted fever, and this is a tick-borne disease. Okay, Coxiella burnetii leads to Q fever. Okay, other than that, a potent question is, this associates with culture negative endocarditis. This particular one associates with culture negative endocarditis. Which one? The Coxiella burnetii. Okay, so these are the various important questions which you focus upon in this particular NEET PG, and you should read around these particular topics also. A lot of topics are there as such, but definitely they are the ones which are being repeated again and again. And if you focus upon these particular topics properly, along with my videos and notes, and stay tuned to the Alan Next YouTube channel. There we does previously also a lot of things, and in the future also we'll be doing a lot of activities regarding the NEET PG, because NEET PG is approaching up, so we'll be having some series regarding the important questions. Obviously there will be more than this, and it will be very beneficial because we try to cover up a lot of things in that particular session. Okay, so very best of luck from my side. I hope you have done good in this, and in the main exam also you will do wonders. So thank you so much. Take care. Bye bye.